This is your lecture on antibiotics, part 2. So we're going to start with what bacteria being sensitive and resistant means. So if you haven't had micro, this might seem a little foreign, but it's important to note that bacteria can either be sensitive or resistant to antibiotics. If bacteria is sensitive to a drug, that means that pathogen is either going to be inhibited or destroyed, which is good. If the bacteria is resistant, then that pathogen will continue to grow, and that is bad. Ways we determine this is through a culture and sensitivity. And this is a good picture, and if you've taken microbiology, this is going to be very familiar. Taking these plates, and then what you do is, let's say, what's a very dirty surface are cell phones. You could swab your cell phone, and then you'll swipe your agar, and then you'll put discs of the antibiotic, and you'll see if it grows or if it doesn't. So we do the culture to determine the organism that causes the infection, and then the sensitivity will determine which antibiotic the organism is sensitive to. So if we need to do, we call it a C&S, culture and sensitivity, we'll draw a culture, we'll send it off, and we'll wait to see what grows. Since cultures can take a couple days to grow, if we're concerned that the patient has a significant infection, we'll start them on broad-spectrum antibiotics until the culture and sensitivity report is back, and then we know which antibiotic we can specifically tailor for that organism. Antibiotic resistance can occur from either a natural or inherent resistance, and that's from no exposure before at all. However, there can also be an acquired resistance, and that is from prior exposure to that antibiotic. So there is a growing problem with antibiotic resistance. A lot of times you'll see providers that are just constantly prescribing antibiotics when it's not necessary. If we constantly are prescribing antibiotics when it's not necessary, we're just creating resistance to that drug, and then those antibiotics are no longer going to be effective. So again, we should not be prescribing any antibiotics if it's not warranted. So one major example, if you've got a virus, antibiotics are not going to be effective for a virus. Antivirals would work, but not an antibiotic. Some examples of what happens when we call them MDRO, multi-drug resistant organisms, are pretty dangerous organisms such as MRSA, methicillin-resistant Staphylococcus aureus, VRE, vancomycin-resistant Enterococcus, ESBL, extended-spectrum beta-lactamases, and CRO, carbapenem-resistant organisms. The first category of drugs we're focusing on are our aminoglycosides. These can be identified by either the icin or mycin. Sometimes we call it the mycin mouse. This acts by inhibiting bacterial protein synthesis, and it's useful for gram-negative bacteria. We do try to reserve this for our very serious infections. It cannot be absorbed into the GI tract, and it does not cross our cerebrospinal fluid. So that means this is given parenterally. We have to monitor our serum levels routinely because there is a high risk of toxicity. So predominantly, we have nephro and ototoxicity. We do need to perform trough levels, typically 8 to 12 hours after that dose. Therapeutic goal for our trough is less than 1 microgram per milliliter. If it's greater than 2 micrograms, there is a very high risk of nephro and ototoxicity. We may need to renally dose these patients, meaning they're going to get a lower dose. One thing unique to our aminoglycosides is there is a post-antibiotic effect where there's a period of continued bacterial growth suppression after the short-term antibiotic exposure, which is a very good thing. This is a pregnancy category C, sometimes D, meaning it can cross the placenta and cause fetal harm. It could actually cause deafness to the neonate, so this should definitely not be utilized in pregnancy. Just as a gentle reminder to remember the nephro and ototoxicity. We should always make sure that we are avoiding nephrotoxic drugs concurrently because that can put the patient into renal failure and a higher risk of ototoxicity if there's concurrent use of loop diuretics. There is also a risk of warfarin toxicity because it does reduce the amount of vitamin K that is produced by the bacteria in our gut. Our prototype drugs are gentamicin. This is given parenterally, topical, and ophthalmic. We can use this for treatment of a susceptible gram-positive and gram-negative bacteria. And we have tobramycin, which we can use for recurring pulmonary infections and generalized infections. As far as our nursing implications and patient education, most important monitoring are baseline hearing because of the risk of ototoxicity and baseline renal function due to the risk of renal injury. Because we do need to monitor our trough levels, we need to monitor our labs routinely and educate our patient that they will have to have a lab stick because of this. Sometimes patients can get really frustrated when they're constantly getting poked, which is very understandable. If you can preemptively let them know you're on a medication that we do have to draw your blood to make sure that it's safe and we want to make sure that you don't have any adverse effects. So just a little bit of education will go a long way. And you should apply the general principles to taking antibiotics as well in regards to patient education and nursing implications. Our next category are fluoroquinolones or quinolones. They're very potent bactericidal broad-spectrum antibiotics. They destroy bacteria through interfering with enzyme DNA gyrase, which is needed to synthesize bacterial deoxyribonucleic acid. This includes gram-positive and gram-negative organisms. We utilize this for respiratory, skin, gastrointestinal, bone, and joint infections. Something that you should absolutely take note of is there is a very serious risk of tendon rupture and tendinitis. Our drug examples, ciprofloxacin or Cipro. This is available as oral, injectable, ophthalmic, and otic. This can kill anaerobic bacteria and atypical organisms, including chlamydia, mycoplasma, and mycobacterium. Our next drug, levofloxacin or Levaquin, most widely used quinolone, and does have broad spectrum activity that only requires once daily dosing, but you do have a higher risk of tendon rupture with our levofloxacin. Your same principles are going to apply for your nursing implications and patient education. One thing that would be different with your quinolones is monitoring your tendon status before, during, and throughout therapy. One of our miscellaneous drugs, clindamycin or Cleocin, is a semisynthetic antibiotic with bacteriostatic or bactericidal properties. It inhibits protein synthesis within the bacteria. This is indicated for chronic bone infections, genitourinary, intra-abdominal, anaerobic, and septicemic infections caused by streptococci and staphylococci. All Enterobacteriaceae are resistant to clindamycin. Our next drug, daptomycin or cubicin, this binds to bacterial cell membranes, causing cellular death. It's used for complicated skin infections due to gram-positive microorganisms, septicemia due to Staph aureus, and infective endocarditis due to MRSA. For our drug interactions, there is a risk of rhabdomyolysis and elevated CPK levels when it's administered with an HMG-CoA reductase inhibitor. These are our statins that we give for cholesterol. There is also a risk of bleeding when taken with Coumadin or warfarin. Our next drug, linezolid or Zyvox, this is a part of the oxazolidinones. These inhibit protein synthesis on the 5-OS ribosomal bacteria subunit to prevent reproduction of bacteria. It's used to manage healthcare and community-associated pneumonia, complicated skin infections, MRSA, gram-positive infections in infants and children. This can also, uniquely enough, strengthen the effects of vasopressor agents, including dopamine. So we may need to be on a lower dose of our vasopressors if the patient is concurrently on linezolid. There is a very high risk of serotonin syndrome if this is concurrently taken with serotonergic antidepressants. Our next drug, metronidazole or Flagyl. This disrupts the DNA and protein synthesis in our susceptible bacteria and protozoa. It's effective against H. pylori and Trichomonas vaginalis. We utilize this in treatment against surgical infections, anaerobic infections, amoebiasis, giardiasis, trichomoniasis, bacteriovaginosis, and acne. Main things we need to note is a disulfiram-like reaction if it's taken with alcohol. The symptoms of the disulfiram-like reaction are flushing, throbbing headache, visual disturbance, confusion, dyspnea, nausea, vomiting, tachycardia, syncope, and circulatory collapse. Patients must avoid alcohol for 24 hours before and 36 hours after their last dose. Our next drug, nitrofurantoin or macrodantin, is indicated primarily for urinary tract infections from E. coli, Staph aureus, Enterobacter, and Klebsiella. This interferes with the activity of enzymes regulating bacterial carbohydrate metabolism and disrupting bacterial cell wall formation. Contraindicated in any cases of allergies and impaired renal function because this drug can concentrate in the urine. There is a risk of hepatotoxicity that can be fatal. So that means in patients that have any sort of impaired renal function or older adults, we need to renally dose and decrease the dose that we would give. Our last drug, vancomycin, inhibits bacterial cell wall synthesis. This is active against several gram-positive microorganisms and can be also used for Staphylococcus aureus. It is ineffective for treating enterococci. We do also use this prophylactically in cardiac surgeries for patients with penicillin allergies. We do reserve this for severe infections that are not responsive to other antibiotics. Main things to watch for: nephrotoxicity and ototoxicity, and something called red man or red neck syndrome. This is not an allergic reaction, rather a toxic effect. It's very uncomfortable. I shockingly had this happen. I unfortunately had to be in the hospital for about a week with a pretty bad infection, and they gave me vancomycin, and relatively soon after the infusion, I started getting really itchy, couldn't scratch it enough, and my face was so red. So I knew what it was, thankfully, from teaching pharmacology, because this is not something that happens very commonly. And I called the nurse and I said, I'm having red man syndrome from the vanco. And she came in and was very confused. And I said, the vanco caused this. Can we stop the infusion? Because it's considered a toxicity. So we had to change the antibiotics, which unfortunately just sometimes happens. This does also have the risk of causing a cardiac arrest, although I have never seen that happen. This is very important. Main takeaways: watch your renal function. If your patient already has impaired renal function, we need to renally dose this or maybe consider a different antibiotic, because even one dose could put the patient into renal failure. We do also need to watch for red man syndrome.